Stroke is Australia's third biggest killer. It kills more women than breast cancer and more men than prostate cancer. Hi, my name is Monique Panoski, and today I will discuss the common clinical manifestations and the underlying pathophysiology that typically occurs to a patient when experiencing a stroke, specifically an ischemic stroke. Let's get started. What is a stroke? A stroke can be defined as an acute neurological condition which results from disruption of cerebral blood flow due to ischemia or hemorrhage. An ischemic stroke occurs due to obstruction of a blood vessel by either embolus or thrombosis, and if left untreated can lead to cell infarction. This concept will be addressed with aid of a case study with our patient known as Mr. Marks, who's a 68-year-old male who was admitted to the emergency department after experiencing clinical manifestations that were indicative of a stroke. These included severe right side weakness, right side facial droop, incomprehensible words, right hymenopia. Upon further assessment, a Glasgow coma score of 11 out of 15 was assessed, and a CT was ordered which confirmed a diagnosis of a left middle cerebral artery ischemic stroke. In order to understand the underlying pathophysiology that caused the clinical manifestations displayed in Mr. Marks, it is important to understand the middle cerebral artery and the concept of an ischemic cascade. The MCA is the largest branch of the internal carotid artery, located at the base of the brain within the circle of Willis. Its primary function is to supply oxygenated blood to the frontal lobe and the lateral surface of the parietal and temporal lobes of the brain, including the motor and sensory cortex responsible for movement and sensation within the face and upper limbs. The branches of the MCA then progress to oxygenate deeper structures through the lentrostriate vessels, which in turn supply the basal ganglia and internal cortex. Consequently, when the MCA is deprived of oxygen, it results in death of cells, known as the ischemic core. Subsequently, neurotic tissue is unable to undergo an action potential, therefore initiating motor responses and interpreting sensory information will be altered. Simply, when a region of the brain is deprived of oxygen due to the MCA, contralateral manifestations are shown. The ischemic cascade occurs due to the lack of oxygen through efficient blood flow. The neurons within the brain lose the ability to create ATP, hence maintaining homeostasis through aerobic processes. Thus, the neurons convert to using anaerobic energy. This creates two main problems. Anaerobic energy produces 15 times less energy than aerobic energy. Due to the lack of ATP, the sodium-potassium pump retains information within the neuron. As the cell releases extracellular water, is drawn into the cell aiming to dilate higher levels of sodium. Unfortunately, the neuron swells, and this is known as cytotoxic edema. In addition, the sodium-calcium pump is also affected due to the lack of ATP production. Excessive calcium encourages the release of excitatory neurotransmitters, that is, glutamate, which creates a vicious cycle of calcium being produced and released to nearby neurons, hence producing more excitatory neurotransmitters. This is known as excitotoxicity, which is damaging to neurons. Additionally, the excess calcium produces degraded enzymes such as proteases, lipases, and free radicals, which attack the neurons, proteins, and the cell membrane, allowing harmful substances to enter the neuron. The second problem is the production of lactic acid. This disrupts normal acid-base balance, which is damaging to neurons. Consequently, the mitochondria releases apoptic factors, which results in cell apoptosis. Now that that's clear, Mr. Marks displayed severe right side weakness and right side facial droop. Both these functions are related to the frontal lobe of the brain, which we know is responsible for movement, behavior, memory, and speech. Situated on the lateral side of the frontal lobe is the motor cortex, which is responsible for voluntary movements. Its primary blood supply comes from the MCA, and due to compromised blood supply within the MCA, the lentrostriate arteries that branch off the MCA are unable to supply deeper structures such as the basal ganglia, which is important for motor control, and the internal capsule, which contains ascending sensory and descending motor tracts from the cerebral cortex that relays messages to and from the face and body. Thus, the neurons within the ischemic core are unable to synapse action potentials to the descending pathway successfully, which results in contralateral hemiparalysis to the right side of the face and body, causing facial droop and muscle weakness, which is displayed in Mr. Marks. Furthermore, Mr. Marks experiences aphasia. This is a common clinical manifestation when the obstruction occurs in the dominant hemisphere, which is usually the left side. Mr. Marks was scored a 2 out of 5 on the GCS, hence speech was assessed as incomprehensible. We know that Speech occurs within the frontal lobe, specifically within the Broca's area, which receives blood supply from the internal carotid artery branching off the MCA. Another area known to correlate with the Broca's area is the Wernicke's area, located within the temporal lobe and is responsible for comprehension of language. We can suspect that Mr. Marks has Broca's aphasia as his words are incomprehensible, but he's still able to obey commands, supported by a GCS motor score of 6 out of 6. The pathophysiology is similar to hemiparesis. When the Broca's area is starved of oxygen, neurons are unable to synapse effectively, which triggers an ischemic cascade of neurons within the ischemic core. Lastly, Mr. Marks experienced right hymenopia, which is the loss of vision to half of the right eye and occurs due to obstruction posterior to the visual chiasm, which leads to contralateral hymenopia. The branches of the MCA provide oxygenated blood to the interior and superior regions of the optic radiations, which terminates in the occipital cortex, to which the MCA and PCA work together to oxygenate occipital pulse. Due to the dual blood flow, if one artery is obstructed, in this case the MCA, the PCA can account for half the vision field due to the crossover of optic nerves in the chiasm. If the obstruction occurs within the left radiation, it results in neuronal death, hence triggering an ischemic cascade. The neurons of the optic nerve tract and the retina are now unable to synapse, hence visual stimuli are unable to be processed. In relation to Mr. Marks, his vision is affected within the right eye, affecting his temporal field of vision. If the condition was homogeneous, it would also affect the nasal field of vision from the left eye. This would occur due to the optic fibers crossing at the optic chiasm, which leads to contralateral manifestations, thus hymenopia. Mr. Marks has a background of hypertension, which correlates to ischemic stroke caused by embolus, as the blood clot is likely to have traveled to vessels within the brain, causing obstruction. To summarize, Mr. Marks experiences clinical manifestations including right side facial droop and muscle weakness, known as hemiparesis, aphasia, specifically a Broca's aphasia or expressive aphasia, and right hymenopia. These occur due to the diminished blood supply to specific regions of the brain due to embolus or thrombosis, which results in an ischemic cascade. Hence, the neurons within the ischemic core are unable to synapse effectively. Thank you for listening.